everybody. My name is Kyle George, and I'm a rheumatology PA with St. Luke's Rheumatology in Idaho. Today, I'll be reviewing the key clinical takeaways from the 2015 ACR and EULAR treatment guidelines for polymyalgia rheumatica, or PMR. PMR is a common inflammatory rheumatic condition in older adults, typically presenting after the age of 50, with hallmark symptoms of bilateral shoulder and or hip girdle pain and stiffness, especially in the morning. Usually, this is accompanied by elevated inflammatory markers as well as a robust response to steroid. Systemic symptoms like fatigue, weight loss, and low-grade fever can also be common. Given the high prevalence and potential for misdiagnosis or overtreatment, the 2015 ACR-EULAR guidelines aimed to standardize the approach to diagnosis and treatment based on the best available evidence at the time. The guidelines recommend oral glucocorticoids as the cornerstone of initial PMR management, with the starting dose of prednisone between 12.5 to 25 milligrams daily. A rapid and robust clinical response, usually within 48 to 72 hours, is a hallmark of PMR and helps support the diagnosis. This early response also serves as a dual role in ruling out mimics such as rheumatoid arthritis, late-onset seronegative spondyloarthropathies, or occult malignancies. An exception to this typical starting dose of prednisone would be in patients that have concurrent giant cell arteritis, or GCA. The guidelines strongly emphasize routine screening for GCA, given that 10 to 20% of PMR patients may develop or have concurrent GCA. Screening is typically accomplished by taking a thorough history and asking specifically about headaches, scalp tenderness, visual changes, and jaw claudication. Immediate action should be taken if symptoms are suggestive of this, and this includes a higher starting dose of steroids, usually 40 to 60 milligrams a day, and also temporal artery biopsy or other imaging as indicated. Tapering is a key component for the treatment of PMR, and the guidelines emphasize that this process should be gradual and tailored to the patient. Generally, the goal is to taper to 10 milligrams daily within the first 4 to 8 weeks of treatment, and then decreasing by 1 milligram every 4 weeks until discontinued without relapse. Ideally, we're aiming for discontinuation of steroid within 12 to 18 months. The taper should follow clinical improvement and normalization of ESR and or CRP. However, this must be adjusted for disease flares, which occur in up to 50% of patients during tapering. A relapse or flare is defined as recurrence of symptoms with or without elevation of inflammatory markers. And the first step would be to reassess for compliance, concurrent infections, or rethinking your diagnosis. After that's been done, you should return to the last effective steroid dose and then resume tapering at a slower rate. Routine escalation to immunosuppressive agents is not recommended unless relapses are frequent or the patient is intolerant to steroid due to comorbidities like osteoporosis or diabetes or something else. The 2015 guidelines gave a conditional recommendation for the use of methotrexate, especially in patients at high risk for relapse or with glucocorticoid-related adverse effects. Typical dosing of the methotrexate is 7.5 to 10 milligrams weekly and often titrated up if tolerated. However, the data supporting methotrexate was modest at best, drawn from a few small randomized controlled trials, and the overall evidence quality was low. I believe that it is also important to highlight that in 2023, the FDA approved Sarilumab, or Kevzara, an IL-6 receptor antagonist for moderate to severe PMR in patients who have inadequate response to glucocorticoids or who require chronic steroid therapy. In the Sapphire trial, Sarilumab demonstrated higher rates of sustained remission compared to placebo, reduced steroid exposure and adverse effects, and improvement in quality of life and fatigue scores. We can reasonably hypothesize that future updates to guidelines will include the use of IL-6 inhibitors like Sarilumab for patients at high risk for glucocorticoid toxicity or relapse. To summarize, the 2015 ACR-EULAR PMR guidelines established a clear, conservative framework focused on low-dose glucocorticoids, individualized tapering, and limited use of steroid-sparing agents. These guidelines remain foundational, but with the advent of biologics like Sarilumab, we may see future updates that offer more targeted, steroid-sparing options for patients with difficult-to-treat PMR. For more information on this and other topics, please check out rap.org.